SICS midterm conference, Dehradun. I welcome you all the participants, all the speakers and my colleagues here. So without wasting much time, we would like to start the session, and we have to end the session by 1:30. So with me, my chairperson, Dr. Sudhanshu Mathur, I am Dr. B.N.R. Subuddhi, convener is sitting here, Dr. Parikit Gogate, and moderator is joining, Dr. Deepak Mishra will be joining shortly. The first talk of SICS, so before, would you like to say anything?
Good morning, everybody. So this SICS session is specially not meant for younger doctors, for junior doctors, but even for the practitioners, because sometimes we are not in the position to do the FACO, and then this is the best choice, alternative choice. Second thing, even the first choice, it is better choice in some cases where we have to control the astigmatism. We can control the astigmatism by giving incision at the steep axis, and this cannot be done in the FACO. So many ways you will learn from the speakers that SICS technique is not less than FACO. It depends upon you which technique you want to do in which case. But we all should know the all techniques that are available for any surgery. So with this we invite Dr. Parikit Gogate. He is a renowned surgeon from the Pune, and I am our vice chairman of our society, AIOCMT3.
Thank you, sir. Thank you, sir. Subuddhi, sir. I have a small talk on how to give 6/6 and 6 vision after cataract surgery. And I've kept it cataract, so it's both FACO and SICS. When I did my residency, this was the most common refraction that we gave, +10, +1.5 into 180 with an addition. Now here, the use of IOLs have done away with the sphere. The use of SICS or FACO has done away with the cylinder. Multifocals have done away with the addition. Because we think that surgeons, we think of best corrected vision. Patients want unaided vision, best for distance and for near. But we have to understand that surgery is not just by the hands, it's also in the mind. Good surgical skill is necessary, but not a sufficient condition for good surgical outcome. We have to plan properly and then execute properly. So for that, of course, a good preoperative workup, and nowadays immersion biometry or optical biometry is a must. Also, we have to look, check, recheck the tonometry, the cornea, the retina. See to it that we have used everything well preoperatively and intraoperatively. NSAIDs drops, mydriatics, high viscosity OVDs. We have so many things in our armamentarium. We should use all of them, and of course have a good, accurate IL-par calculation. In this, the thing that differentiates FACO and SICS is astigmatism. FACO gives 0.5 astigmatism, SICS gives 1 to 1.5 astigmatism. So as Dr. Sudhanshu said, if we take the incision on the steeper meridian, and if we know our surgically induced astigmatism, if we are doing a FACO, this is what we will do. We will put a toric lens to take care of that. But even with large planned incisions in SICS, we can take care of the astigmatism. And of course, we nowadays have LRIs and femto-assisted corneal cuts. So we have to manage even the post-op surprises. And before we go ahead, we have to choose what is it that the patient wants. So some patients want to do near work more, like embroidery, watchmaking, goldsmiths, readers. Many of them, especially those who work outdoors, drivers, travelers, marketing people, hawkers, pilots, policemen, they want good distant vision. But majority of our patients want good unaided intermediate vision. Computer experts, painters, musicians, cooks. Once we know that, and then how much is the patient willing to spend? Yes, trifocals, high-end EDOFs are great, but everyone can't afford a Zeiss Acrylisa or a Vivity or a Synergy. So what can we do for them? One, we can do monovision, mix and match. One eye distant dominant, one eye near dominant. We can do smart SICS, or we just keep a small residual refractive error. Because in the end, patient doesn't remember how much he has spent. Patient remembers if he can see well without specs for most of his work. If he is able to do that, he's very happy with us. If he's not able to do that, he's not happy with us. We have phaco patients whom we are happy because next day they are reading 6.9 or 6.6. But they are not that happy because they say earlier I could see my messages without specs. Now I need specs. I can't see my phone. I can't read the newspaper. So we have to choose the technique and the IOL and guide the patient to it. So for some kinds of cataract, phaco is best, infants, children's, young adults, soft cataracts. But for very hard cataracts, lens-induced glaucomas, compromised corneas, chronic uveitis, perhaps SICS is far, far better. These are Dr. Boramani's slides. So he has been centering the incision on the steep meridian. And depending upon where the steeper meridian is, we get 180 degrees for both the eyes to choose from. And if we do that, then if it's a very, very small frown incision, it will just give 0.25 or 0.3 SIA. But if suppose this is a high astigmatism, like 3.3 diopters, if we do a phaco in this, we will have to put a toric lens. But if our patients can't afford a toric lens, or we are working in a place where toric lenses are not easily available, what do? We can take a larger incision on the steeper meridian. So like yesterday when there was a live surgery demonstration, I was doing a live surgery SICS and the steeper meridian was 70 degrees. It was slightly supero-nasal and the pre-op astigmatism was 1.5 diopters. So theoretically, if we would have done a phaco, we would have put in a toric lens because anywhere more than 1 diopters, we advise torics. But because it was SICS, I took the incision supero-nasally. Yes, the incision had to need a suture later, but because of doing that, this astigmatism can be completely neutralized. So an astigmatism of 3 diopters can be completely taken care of. So if we are able to do that, even without putting torics, we can use EDOFs or even multifocals with SICS. And it will give us equally good results and at a much, much lesser cost. So here again, we have taken a straight supero-nasal incision. So doing this, we can modify the astigmatism the way we want. And the post-op refraction is of course 6.6, it's about N6 or N8 for near. So it's not like surgically induced astigmatism, we can call it surgically corrected astigmatism. And it's not SICS, it is customized incision cataract surgery. So when we have a patient, we have to look at the patient's needs, we have to look at the patient's budget and his ability to pay and also his willingness to pay, because we have seen many a times patients are able to pay but they are not willing to pay that much for cataract surgery, in which case we can choose the technique and we can give the best results. So we always promise less and we deliver more, because by doing that we have happier patients. And while doing this, of course, we have to respect biology, and regular and complete follow-up is very, very important. So once that is done, I think any kind of patient that we have, any kind of cataract that we have, with any kind of budget that he has, we can still have a very, very good vision. I would like to again acknowledge the scientific committee of AIOS, Dr. Satanshu, Dr. Gaurav for the kind invite. And we have our CCC, our annual conference that is coming up. So please block your dates and we hope to see you in Delhi in November next year. Thank you.
Thank you, Dr. Parikit, giving the overview of how to get the 6/6 vision in the SICS also. So I request Dr. Rajendra Kaur to speak, the next speaker. Simply speaking, MSICS is surgery for all seasons and all regions.
Good morning, everyone. Thank you, AIOS and the International Society of Manual Small Incision Cataract Surgery for giving me the opportunity. So my topic is Manual Small Incision Cataract Surgery, a surgery for all seasons and all regions. So commonly encountered challenges when we decide to do the manual small incision cataract surgery, it is the rocky hard cataract, intumescent cataract, hypermature cataract, undulating pupil, shallow anterior chamber, previously operated trabeculectomy, small eyes and hazy cornea. So I will be showing you the videos. So this is a case of that is hardback cataract, brown cataract, and manual small incision cataract surgery. I believe that there are 2 points in that: a big scleral tunnel, a big rectus to do a wonderful surgery, and of course when there is astigmatism, you can plan your incision on the G-back. So in this cataract, use of adhesive viscoelastic can prevent your endothelium in the cornea. So it is always, and it should be a safe delivery. That is very comfortable delivery which results in very good results. So the take home message in hard cataract is big tunnel and big rectus on a small eye. So whenever you are in doubt with the knowledge, don't ever hesitate to do sutures. Now the non-dilating pupil. So increased tissue damage is there, retained lens matter, vitreous loss, cyst and macular edema when there is more manipulation. So non-dilating pupil, that is they are commonly seen in pseudo-exfoliation, diabetic patient, chronic use of miotics, uveitic patient, senile miosis, atonic pupil and iris sphincter fibrotic. So in these cases you can use various devices for pupillary expansion, shifting from topical to the peribulbar. It is the best choice in these cases because the iris will be manipulated, so the patient may feel pain. So it is better to give the peribulbar block. So the high molecular weight viscoelastic agents and the iris hooks can be used, and you can stretch the iris with the Sensky hooks also. So it is another case showing the in this case the we will be manipulating the iris, so it is better we can do under the peripheral block anesthesia. So you can stretch the iris, and sometimes with the stretching of the iris the pupil dilates, and the delivery of the nucleus into the interior chamber in stretched pupil is not a problem after that. So at this time I had the irisostomy. So it is now well stretched. So we can deliver the nucleus even without the irisostomy. Now in the hazy cornea, the main thing is so always with the triple blue guide in your interior capsule, so that if it runs you can see the capsular margin. So it is always the same reason that is the triple blue guide in this case. So using a fiber, the manipulation of the nucleus with the iris or the sensory dialer is not a problem in such cases. So iris should be placed within the capsular bag to avoid the captive capture. So you can discuss it OVD injected before the surgery for the better visualization. So it is very interesting case. She had another case. After that she has the phacomorphical coma in the eye. So as the patient had a mature cataract and she was not willing to pay for the higher lenses. So SICS was planned in this case, oral SICS in the buccal eye. So in buccal eye we faced the problem that the interior capsule is bulged forward, and she was a case of phacomorphical coma. Even after that is injecting mannitol, it was bulging, interior capsule was bulging. So rexis was a real challenge in this. So, but the patient was very happy post-operatively. Patient was even in the buccal eye she was maintaining staging vision. So PCC is a real challenge in these cases. So the customized as the Dr. Bonamani's technique is coming. So I am also, previously I was not doing the temporal SICS, but after that I was encountered with the customized manual small incision cataract surgery. So whenever I feel that there is astigmatism, so I am doing now the temporal incision in the I just wanted to show the astigmatism. Oh, that is not. So it is another interesting case, manual small incision cataract surgery in a case of aniridia with Morgagnonian cataract. So in this case also I planned the temporal SICS, and there is no iris in this side, and even in this case that is rexis was challenging in this case also. So I was injecting, I was not holding, so you can see the wrinkles on the anterior capsule. So it was a real challenge. Then I took the help of the intraocular forceps and scissors and to complete the rexis, and then I put the Enridia oil in the sulcus. So the patient is very happy with the, previously he was only hand movements. So then after that he is now maintaining 6/24 vision because he had since the childhood. So because of amblyopia reasons he is maintaining 6/24. So universal applicability is there. It is an art. Every ophthalmologist should be well conversed with this technique and boon for residents in their learning curve. Thank you so much. Thank you.
Thank you, Doctor, for those wonderful videos and a very good talk. Now I would like to invite Professor BNR Subuddhi, a very senior in our field and who has maintained teaching and academics with private practice, high-end phaco and also SICS. He'll be speaking on nucleus removal by the sandwich technique.
Good afternoon. So my previous speaker already told about the different techniques of SICS in complicated cases. So however, I was thinking because how for the youngsters, how we can achieve a good result with a very simpler technique, that is a phaco sandwich technique. So as you know, MSIC is now the most preferred technique of cataract surgery, widely practiced in both developed countries and developed countries. The most, I would say, that is AIOCMT cataract surgery, I would say, because the most of the our insurance is covered by the AIOCMT Bharat, and we do most of the time SICS only. And it involves the extraction of the nucleus either complete or divided manually from the capsular bag and then through the sclerocorneal tunnel incision. And nucleus extraction is one of the most important step in the cataract surgery, particularly SICS surgery, and lot of techniques have been evolved over the time, and these techniques have their merits and demerits. It depends upon how you practice and how you get the good result. However, they give similar results in the experienced surgeons. So they are the different techniques, one by Blumenthal technique, then micropractice technique, phaco fracture technique, phaco sandwich technique, fish hook technique, Ruiz technique, and snare technique. In my hands, I would keep that phaco sandwich is one of the best technique, very simple technique, easy to learn, early to learn also, and giving the best results out of all the seven techniques. Whichever is compatible to you can do it, but definitely for the youngsters, those who are first time doing the surgery, they can use this technique of phaco sandwich. It's introduced by the Luther Fry in 1985, sandwiching the nucleus between the lens loop and spatula, and it's a two-handed technique, and it's modified by using wire vectis instead of the spatula. You can use the wire vectis so that you can visualize what you are pulling out from the eye. So this is the technique. Okay. Technique that is inject viscoelastic. Once you complete the section, you're going to, and also you have done the rexis. Both inject viscoelastics above the endothelium, above the lens to protect the endothelium, and make a good space for the putting the Sinski hook, and below space to introduce vectis. So push iris diaphragm back. So very carefully see that your posterior capsule is pushed quite far. Introduce vectis below the nucleus, carefully see again while passing this bacteria under the nucleus, so that you will not catch the iris at any point, and also will not injure the poster capsule. Anyhow. So this technique ensures the safe nuclear delivery with minimal iatrogenic insult. And entry instrument that SICS will help in protect the endothelium, and the special designed corrugated microbacteria will protect your poster capsule, so that you will not injure the poster capsule while they are in the nucleus. The enlarged internal tunnel allows the nucleus to rest in it and come out total without damage the endothelium. So in this technique, the established surgeon's two hands, which accounts for the safe delivery of the nucleus without injuring either endothelium or poster capsule, and also there is any chance of nucleus drop also, because you are everything visual, you are seeing that. So this can be adapted safely in hypermature cataracts where journals are weak and very hard nuclear cataracts. So complications are very, very less, very, very minimal. I would say that intraoperative damage the corneal unless you are very careful, you will injure the endothelium. Iris dialysis, yes, very much while introducing this spatula posteriorly, you must be very careful. You are not catching the iris at the 6 o'clock position, and similar at the 12 o'clock while pulling out the 12 o'clock position iris. Post-operative, definitely if you manipulate more, you will expect a striate keratopathy, but if you manipulate less, you will less keratopathy, and corneal advance very less. So why Phaco sandwich technique? It's a very simple technique, easy to learn, no learning curve, less instrumentation, a clear cornea. Demerits, sometimes you require larger section, because if the nucleus is very hard, you can go for larger section, may induce astigmatism. So for our students in medical institutions, first we teach this Phaco sandwich technique. Then once you master this technique, you can go for the other techniques of nucleus delivery. So our surgical goal is to protect the corneal endothelium and protect the capsular and poster capsule. So following these are the three principles where how to produce it. It's a learning curve. You do a wider sclerocorneal section tunnel, a bigger axis so that nucleus, whatever the size of the nucleus, you can pull into the antechamber, and use adequate OBD. That's very important. As much as possible of OBD, so that you should not injure the both endothelium and the poster capsule. So to conclude, Phaco sandwich technique for nuclear delivery in the nemesis is one of the best and simplest technique. Before I end, I'll show you the video. Just I'll show you the video. Introduce the bacteria posteriorly, taking care not to injure the iris at 12 o'clock position. Yes. Very simply, automatically comes out, nucleus comes out. Sorry, it's gone somewhere. कहाँ चला गया? Okay. So thank you very much for listening to my talk on Phaco sandwich technique. I think people sitting in the back, I think a lot of postgraduate students are there. So I think it is one of the best technique you can learn easily from your teachers, from your masters, and you can practice even in the wet lab also. Thank you very much.
Thank you, Professor. Thank you for those tips. And I would now request Dr. Jayashree Barua, our professor from Assam, to give her talk. She will be speaking on topical SICS tips and tricks.
Yeah, very good afternoon, everyone. So today I'll be basically discussing on topical MSICS, the tips and the tricks. It's not how we do the SICS, but what modifications that we can do in order to shift from our peribulbar injections to the topical M6. So why are we discussing about topical anesthesia? Because this is the ultimate form of low risk and non-invasive technique. But at the end, I'd like to say that it depends upon your technique, your confidence, and it's a personal choice whether you want to shift from peribulbar to topical M6 or not. So is topical anesthesia safe in M6? Is it possible to do M6 in all the cases that you are operating upon, or do you need to modify some of your steps when you are doing topical anesthesia, under, the cases under topical anesthesia? So we have a wonderful kinesia, we have wonderful anesthesia with peribulbar injection. The patient does not complain of pain. You can do a very good surgery. So do we need to move away from our comfort zone of anesthesia and kinesia, which is present in peribulbar anesthesia? See, like in any other technique, there should always be a scope for improvement. And if we are giving this benefit to our FECO patients, why not give this benefit even to our SICS patients? So before jumping into any conclusion, I decided to see what are the differences that I have in my FECO and my SICS cases. And this is not a one day that all of a sudden I decided to jump. It was after operating 40,000 cases of SICS under peribulbar. And it was, then I realized that it was only after my 30th case of echoemulsification that I shifted to topical anesthesia. So what was the difference in the technique that I was doing? Okay, I was doing a surgery that was taking me 10 minutes and I was doing it under topical anesthesia. And on the other hand, in SICS, I'm doing a surgery that takes me 3 minutes and I'm giving a peribulbar block for the patient. So where was the difference? So why was I not doing topical anesthesia before? Maybe I was worried that the patient will have pain, patient will complain. We are giving a bigger incision, so maybe the incision will be difficult. I was at that time still using the superior rectus bridle suture, which I don't use now. What if I get a hard nucleus? What if I land up in a complication? Then again, I'll have to shift to peribulbar injection. Or was I looking for an excuse of avoiding because I was comfortable with peribulbar injections? So I decided to go back and see the anatomy where exactly we are operating. So we have our sensitive terminations of the fifth cranial nerves that are concentrated in our cornea and our ciliary body, and these are the positions where our anesthetics are working. And these nerves are blocked by very minimal concentration of your anesthetics that you are using. So definitely we have the advantages of topical because you have a higher safety level. You don't have the complications associated with the peribulbar injections. You have a lower intraocular pressure and you have the patient quite comfortable immediately after surgery. You don't need to give the patch to the patient. But yes, there are the limitations when you actually begin with topical M6. You have to avoid uncooperative, anxious patients. If the patients have any communication problem, or you are anticipating long surgeries, or you know that it is a complicated case, maybe you can shift to peribulbar in such cases. So the technique is the simplest of all. You just need to use the proparacaine eye drops before your surgery. But today we have the intracameral injections that work wonderfully. The technique is the simplest in itself because you just ask the patient to look up, instill a drop of proparacaine, just ask the patient to close his eyes and your job is done. And initially it can be, when you're starting to do topical, it's a good practice. If you give the drops in both the eyes, then it will eliminate the squeeze response of the patient and you'll be more comfortable doing your surgery. So there are 3 ingredients for success when you shift to topical. You have to prepare your patient, you have to select your patient properly, and you have to be prepared. You yourself have to be prepared to undergo this, to perform the surgery. So in patient preparation, educate preoperative counseling is very important, where again we have 4 specific issues I'll be showing in the videos. So the microscope light, it appears to be very bright initially for the patient. So start with a dim illumination and then gradually increase your illumination. You have to remember that you still have the intact eyelid sensation unlike your peribulbar. So thirdly, you have, it's comfortable if the patient can follow your command and you can control the eye movements, and it is very normal for the patient to feel some pressure sensations when you are operating under topical. So this has to be explained to the patient beforehand. Next comes how you select your cases. Here again we have 4 points. So there should be no language barrier between you and your patient. Patient should follow your instructions. Choose the easier and the simpler cases initially. Don't directly jump into hard and difficult cases. Check for the squeeze response of the patient. How you do this? When you are seeing the patient in the OPD, you are doing the AT, you know if the patient is not cooperating with those procedures, he is unlikely to cooperate with your surgery. And next is you need to check for the eye movements of the patients. So with this preoperative counseling and a careful case selection, you will maximize your chances of success and minimize the stress factor both of the patient as well as the surgeon. So what about our preparation? Here again we have 3 specific issues which I will be dealing with one by one. So saccadic eye movements are disconcerting, but sudden and forceful gaze movements can be a problem, so you need to seek the cooperation of the patients. We have to remember that any amount of stimulation of the eyelid or the traction on the speculum or even the subconjunctival injections, if some of you are giving, then these will be painful for the patient. So the iris also retains its normal sensation. So this is the time when you are delivering maybe a hard nucleus, you can go for the intracameral injection so that the patient is comfortable and you can comfortably do the surgery. So what are the deciding factors? It's the patient, whether the patient is willing or not. It's you as a surgeon, what are your skills, and it's the type of cataract or the type of the comorbidities that you are dealing with. So these are the immediate post-op pictures of a few of my cases, and these are the smiling faces. A patient comes back without the patch, goes back without the patch. A happy patient, especially your mad cats, you know, the moment they can see immediately after surgery, that is something that gives you as much happiness as the patient himself or herself. So hopefully this presentation has helped you in improving your confidence, maximizing the chances of success, and you can enjoy your experience of M6 surgery. Thank you.
Thank you, doctor. Thank you for those wonderful things.
Both patients and surgeon both are happy. I saw the picture.
We will take all questions at the end. Then I would request our next speaker, Dr. Priyan Suman Rastogi, to speak on complication management.
Priyam is the professor and they are in the Muradabad Tirthankar Medical College.
Be a member of AIOCMT3. You are an international organization.
First of all, I would like to thank AIOS and Satanshu and Subudhi sir for having me here. So I'll be speaking about intraoperative complications and difficult scenarios. Of course, this presentation is quite basic presentation, and I prepared it for the PGs. I can see quite few of PGs here, and young surgeons. So any difficult situation intraoperatively can land you in a complication. So I'll be discussing those basic conditions. These conditions might be quite easy for an experienced surgeon, but for a learner, for a resident, they can cause a big trouble. So in my experience of past 15 years of teaching, I've seen that there are complications at 2 stages in a surgeon. First, when he's a beginner, and second, a trained SICS surgeon shifted to phaco, learned phaco, and comes back to SICS for 1 or 2 odd cases, because he is more accustomed to phaco and comes to SICS, then he is more tend to develop that complication. So what are the eyes prone for complication? High myopic eyes or high hypermetropic eyes, post-traumatic eyes, deep set eyes with sunken eyeballs, obese patient with thick neck, hard of hearing or uncooperative patients. These are the most common cases what I've seen land up in complications. So I'll be dealing with some basic complications. I won't be discussing about PCR and nucleus drop because they are most often talked in all the conferences. So first is premature entry and intraop iris prolapse. They go hand by hand. So what it leads to? It leads to premature entry leads to an unstable anterior chamber, iris trauma, and iridodialysis. And how to deal with it? If there is a premature entry, you can be managed with a tunnel in a new plane. You can go below that entry, or you can suture the point where the entry has happened premature and continue surgery with that. Then if there is a premature entry, it most often lands up in an iris prolapse. So or other side also you can land up in iris prolapse. So first is rule out a floppy iris syndrome before surgery, and try to do maximum manipulation of the side port, suture the main wound and manipulate between the wounds. Intracameral pilocarpine, sometimes it helps, and avoid overfilling the anterior chamber with viscoelastic. Stop the urge of immediately repositioning the iris. This is most important. See, in this video, the surgeon, he is repositioning the iris with a Simcoe cannula. And this is bad because this can do a trauma to the iris, this can do iridodialysis. This is not recommended. You can decompress the anterior chamber, reposition with the swiping movements. Like in the second video, here surgeon, she's repositioning with the swiping movements over the iris. Just press over the iris and swipe over it. This is the most recommended method for repositioning the iris. Then The next complication is iododialysis. The most common steps where the iododialysis happen while doing the main wound entry, while doing the side port entry, doing the nucleus delivery. While doing the main port entry, you can push the iris with your crescent or a kratom. While doing the nucleus prolapse, you can engage the iris, either inferior part or the superior part, and pull it with it. You can cause inferior iodolisis, you can cause a superior iodolisis. This is a very common iodolisis situation in young residents. Prevention is gentle and meticulous tissue handling, and in my way of treating is I take a mechanical suture. There are different ways of, there are different methods like hang wax suture or cobbler suture, but I prefer a mechanical suture for treating it. Then this is one more common complication, that is buttonholing while doing a tunnel. Now this leads to distorted tunnel anatomy and creates a leaky tunnel. So what you can do is you can just create a tunnel in a new plane again, just below that buttonholing. So that will tamponate the upper part, that is leaky part, and you can continue with the surgery itself. Then this is a common complication what I have seen in many residents, that while making the side port entry, they hit the anterior capsule because they can't judge the depth of the anterior capsule. So this is, in this case, you can see the surgeon is entering and he hits the anterior capsule. So it creates an opening in the anterior capsule. You can easily manage it by just considering that entry as a flap, and you can continue with the rhexis with the same flap, and you can continue with the surgery. Then common capsular rhexis and hypermature category milky fluid. It normally obscures the vision. Chances of capsular rhexis extension at the periphery are very high. And once that fluid seeps out from that bag, the bag becomes very lax. And because of the small nucleus, you don't have that support of capsular rhexis. So the capsular rhexis becomes difficult in these kind of situations. So you can use what you can do is you can use a capsular rhexis forceps, or you can aspirate the fluid by making a small entry into the anterior capsule, or you can do a spiral capsular rhexis before starting the main capsular rhexis. And keep the chamber inflated with viscoelastic while doing this capsular rhexis. And my way of doing it is, what I do is normally I attach the needle with the infusion bottle and do a rhexis with that. This thing keeps the chamber inflated and keeps on swiping out the fluid, whatever is coming out from the chamber. Then agnatinal flex sign, fairly common. What can be done is, both the flaps of the rhexis, they can be converted into a circular rhexis, or you can do a canopter if not comfortable, because these kind of capsules are normally very fragile and they tend to extend to the periphery. Then iris prolapse to the side port. This happens when there is side port is not made properly. Now the point is that you should not push the iris from outside. What you can do is you can take a cochlear hook, or you can take a iris repositor or a dialer, and you have to pull it from the main port. You can go inside from the main port and pull the iris inside. So that is a trick here. Then inadvertent staining of the posterior capsule. For a new surgeon can be a difficult thing. The cortical aspiration becomes difficult, so you must recognize the situation and do a cortical aspiration carefully. Then localized DM detachment intraoperatively can occur due to traumatic entry or traumatic touch by instrument. So can be managed by intraoperatively by repositioning the flap with a viscoelastic and by injecting the air or bubble or gas, tempering the flap at the end of the surgery. So in this case you can see this is runaway rhexis, fairly common again. So first case the surgeon is not able to regain the rhexis. In the second case here, surgeon was able to get hold of the rhexis and finish the rhexis with the forceps. So if there is a runaway rhexis, you can use a forceps, or you can pull the rhexis towards the center to manage it. If not, then anyway you can start the rhexis from the other part of the other margin of the rhexis, and you can complete the rhexis that way. So other situation, small capsule rhexis, large nucleus. So how can you manage it? What you can do is you can give back cut incisions in the capsular margin, but avoid giving incisions in the inferior part, because when you dial the lens inside, those incisions or those relaxing incisions, they can progress and they can go up to the periphery. So always give either in the superior part or on the sides. Then small tunnel, large nucleus, again a difficult situation. As you can see in this video, that surgeon is trying to pull the nucleus out, but it stuck in the tunnel. So you can give, in this situation, you can back incisions, or you can divide the nucleus into two parts and remove the nucleus one by one. Then intra small pupil, I think it has already been discussed. Various modalities, the intracameral adaline, iris hooks, pupil stretching technique, etc. They all have been discussed. This one is for cochlear hook. You can just stretch the pupil and you can complete the surgery. Then we have zonular dialysis. So it happens most commonly during the nucleus prolapse in AC because of the maximum manipulation, or during the cortical aspiration. If it is less than 2 o'clock hours, you can place the lens very well in the bag, or if it is a rigid IOL or a multi-piece IOL, you can just put the haptic part in the dialysis area, or if it's more than 2 clock hours, you can prefer a CTR with dial placement in the bag. So my take-home message is a thorough pre-op evaluation is a must in every case, a meticulous step-wise approach to be followed in case of complication. Complications are part and parcel of the surgery. Keep calm and never hesitate to call for help in learning stage. Thank you.
Thank you, Professor, for those steps.
They were teaching steps.
I would request now Dr. Sanjay Tekavade, our senior PECO and SICS surgeon from Pune. Please come to speak on the retro expulsion of nucleus.
Thank you, Dr. Satanshu, Dr. Subodhi. This is basically a surgical video. Can you run it? We saw the different techniques of nucleus explanation. I think Dr. Subodhi just mentioned various techniques. I'll be adding one to it. It's called retroexpulsion, or you can, it's an endo expression of the nucleus. Basically, it's a surgical video. Once you make the adequate incision, capsular access is one of the most important step of cataract surgery. I use the technique of capsular marking with air bubble CCC. Here you can see the capsule stained with Lipandu. The size of the capsule is very important, especially with SICS, because now most of the training starts with PECO, and we all are getting used to smaller axes. Though they are good for your PECO emulsification, sometimes they are inadequate for SICS. And I've seen most of the complications occur because of smaller size of axis. So sizing your axis is very important in SICS, especially if you have a harder cataract. So take time on axis. Staining is very important, and as I showed, use an air bubble assist technique so that you get a marking onto the cornea of the expected or the desired size of the axis. So here I am making an axis adequate for that nucleus. So this is a hard nucleus. You get the nucleus out of the bag by, this is the cartwheel is the best technique in my hands. What I am trying to show is how you minimize the instrument inside the incision so that you can keep your incision to the least possible. So you engage the nucleus into the incision and then you expulse it out by pushing it from behind. So this is an endo expression of the nucleus. You can see any side of the nucleus will come out. Now here, over a period of time, you have modified the techniques. Once you rotate or dial out your nucleus out of the capsular bag, what we do is we now use our routine BSS or irrigating fluid. Here we are engaging the nucleus into the incision and to pressurize the chamber, because to get the nucleus out, you have to pressurize the chamber. To pressurize the chamber, we are using normal irrigating fluid. So once you pressurize the chamber, the nucleus will come out easily with little manipulation. So we are not using the main incision. That keeps the incision to the minimum, because as we saw in the previous talk of and DNR, size of the incision is important. That will restrict your astigmatism. This is in a white cataract. Again, you rotate or dial the nucleus out, judge the size of the incision, and once you feel the incision is right for the nucleus to come out, engage the nucleus in the incision and get it out. So any kind of nucleus you can manage with this technique of endo expression or reticular expression, and you can continue with the same instrument. So you do not use any instruments through the main wound. What we're trying to show here is you use the instruments other than in the main incision. So you can continue with your cataract surgery, your nucleus, after the nucleus expression, you can continue with your eye and your lens implant. This is a small pupil, sometimes challenge for an SICS surgeon. But again, if you make an adequate capsular access, things are easier. Here be gentle on your hydro procedure because you don't know, sometimes overinflation can cause PC rupture. Though the pupil is small, you can manage with this technique of dialing out the nucleus. You can see it's quite large, and then we express it out. You're just debulking, getting the loose cortex out. So quite a large nucleus. Again, we use a technique of hydro expression or endo expression. We are pressurizing with the irrigating fluid and pushing out the nucleus. So we keep minimum manipulations inside the incision, and we continue with the same instruments that we use for nucleus expression. So one more addition to nucleus expression technique is quite simple, doesn't require any additional instruments, and redoable. Thank you.
Thank you, Takeaway sir, for showing that video and explaining to us in great detail.
Excellent videos. Really wonderful videos.
Thank you. Thank you. Thank you.
Thank you. I always find difficult to call his name, so I remember name. Take away food hota na, take away for McDonald, take away. Takwade. That is Akshay.
Dr. Chetan Ahivare has been a senior trainer with Help Me See.
Oh.
And with Help Me See for the last 14 years, they have tried to make, they now have a good SICS and a FACO simulator. We were lucky to have that in our medical college, D.Y. Patil Medical College, for almost 7 months. And what a surgeon will perhaps take 50 surgeries to learn, that can be done on the simulator just in about 5 or 6 days. And it really helps reduce complications, eases learning. So over to you, Dr. Chetan. Please enlighten us.
Organizing committee, scientific committee, our respected panelists, and AIOCMT3 for providing this platform. My topic of presentation today is learning M6 the Help Me See way. Financial disclosures, I'm a consultant with Help Me See and work there as a subject matter expert and chief instructor. So for those of us who are not aware about Help Me See, it's a non-profit organization based out of the US, and its mission is focused at eliminating preventable blindness from cataract worldwide, the incidence of which is currently 100 million. And we do this by offering simulation-based training in ophthalmic surgeries. So the picture that you see here is of Albert Ucci. He is founder of Help Me See, and he was also a co-founder of Orbis International. We all know that Flying Eye Hospital from Orbis International was a big success, but it had its own limitation, and it was not possible to scale up the efforts that we were putting in eradication of cataract blindness. So he came up with this novel idea of creating the Help Me See simulator. Okay, so this is the picture of the Help Me See eye surgery simulator. It's the only simulator in the world which simulates the M6 procedure, and it's the only simulator which has tactile feedback, and it's the simulator where we can use for performing the incisions. And let's play this video. I think there's something wrong with the slides. So as you can see here, the tunnel construction step is being performed. We have the crescent in the right hand and the colibri forceps in the left hand. And as you perform the scleral groove, you can actually feel the resistance that the sclera offers and the resistance that we feel while dissecting the sclera and the cornea. While we are doing this, you know, a trainee might go superficial and create a buttonhole, or might go deep and end up in a premature entry. So all these complications are simulated on the Help Me See simulator. You can see how intricately the graying of the cornea can be seen. It's quite close to how we see it in the real surgery. Steps like making the paracentesis injection and paracentesis and injecting viscoelastic and capsulorhexis, all the steps can be performed on the Help Me See eye surgery simulator. So this is the list of the advantages that simulation-based training offers, and out of the list I would just like to highlight a couple of them. Like it allows repeated practice, and thereby we can safely train all the trainees in all the steps of SICS. It can help us learn from our mistakes, so the trainees can really understand whether how they are tilting the blade, how fast they are cutting, and what is causing them the complications. We can also objectively measure the performance parameters, so we can measure the length of the tunnel, we can measure the depth, how deep the dissection was. So we need evidence to support you know, that what we are doing is helping, and these are all the studies. There are a lot of studies which have proven the benefit of simulation-based training, but the studies that you see here, they are based on the Help Me See eye surgery simulator. So we have enough evidence to show that training on the simulator does help in the live surgeries. But more than this, it is the feedback that we get from the trainees and from their mentors about how the trainees have improved post the training. That is the incentive that keeps us going. So how is Help Me See training different from traditional training? First of all, it's a proficiency-based training. We have a structured program. We perform objective assessments on the simulator, and it is also an instructor-led program. So by proficiency-based training, we mean that we train each trainee until the trainee demonstrates proficiency. So they have to do repeated practice, and we review their performance parameters. We can objectively measure how they are performing on the simulator. And after each session, we do a debriefing with the trainees to know what they have learned and what difficulties they faced. We also do the grading, and we use training tools and guidelines. So you might have seen in the video there were some green lines telling us how much they should dissect and where should be the location of the paracentesis and things like that. So we offer 1-day or 4-day courses. Currently we have SICS training, we have FACO training. All these are 4-day courses, whereas we also have a short 1-day courses where we train in complications management. I'm going to show the list of courses that we cover in the next slides. But as I said, we have a very detailed schedule, and what the trainee does on day 1 and day 2 is already planned. So on day 1, they would normally start with making the paracentesis, injecting viscoelastic, and creating the tunnel. On day 2, they would perform capsulorhexis, hydrodissection. On day 3, we train them how to deliver the nucleus out, and on day 4, they just learn the simple steps of IOL injection and hydrating the paracentesis. We also have good e-learning modules which prepare the trainees before they land up at the simulation training center. And as I said, at the end of the training, we do assess the trainees how well they are working on the simulator. So we make them do 5 attempts, and out of those 5 attempts, they have to show at least 3 satisfactory attempts. And the training tools and guidelines that we have used during the training, we don't allow them to use those training tools. And the pass criteria, as I said, is 3 out of 5 satisfactory attempts. So it is instructor-led. We always have an ophthalmologist around to guide the trainee and to correct their mistakes. These are the pictures from our Mumbai training center. We have multiple simulators there, around 7 to 8 simulators, and sometimes we have batches of 8 residents attending the training, and we train all of them. As I said, a trained ophthalmologist is always around to guide through the simulation-based training. There was a time when we were also doing remote training. Now this is a picture from DY Patil Medical College, and this is during the COVID times. You will see all the residents are in their masks, and we did not want the surgical training of these residents to take a hit, because during COVID times the opportunity for surgical training was very less. So during those times we did what we call as the remote training. So the trainers were sitting in Mumbai, but the training was happening on the simulators in Pune. So it was very helpful for the trainees to learn in a safe environment without compromising patient safety. And we could continue with some of the surgical training during COVID. So this is the list of the surgical procedures that we have on the Help Me See simulator. As I said, it's the only simulator which simulates SICS. It is the only simulator which has suturing on it, and it is the only simulator with tactile feedback, wherein you can feel the different tissue dissection, the resistance offered by the tissue. We also have vitrectomy now, recently added, both anterior and pars plana vitrectomy. In these courses, we train the surgeons on inserting the trocar and cannula, performing pars plana vitrectomy using an automated vitrectomy cutter. And we also have a phacoemulsification course which has the foot pedal, just like how we have in the real life. So there are multiple components of the training. We have the e-learning, we have classroom sessions, we have debriefing sessions, and of course we have the simulator sessions. This is the picture that the trainer gets to see. So this is collected from 4 different simulators, and at any given point of time we can monitor all the 4 simulators. I just want to show the different centers that we have across the globe. This is a center in Germany, it's in France, in Strasbourg, where we have trained 4 doctors who are now training on the simulator. We have also partnered with LV Prasad, where we have 2 simulators, and we have a well-established training center. This is a picture from Arvind. We can see Dr. Shankar Anandan here, who is our lead instructor, and we have conducted a lot of camps as well. Recently, we started a new center at AIOS headquarters. We inaugurated this center a couple of months back, and we have placed 2 simulators there, and a lot of training is happening there. Every week we get around 6 to 8 trainees who want to learn on the simulators. This is our another partner, Shankar Eye Hospital, Bengaluru, where again we have 2 simulators. We have set up a sim lab, and a lot of training is happening at this center as well. Another center at Shankar Netra Chikitsalaya, Eluru, Vijayawada. So to summarize, simulation-based training is a game changer. It's an innovation with great potential, improves patient safety, and shortens the learning curve of the trainees. So may have a role in certifications of surgical skills going forward. Thank you all for your kind attention.
Thank you, Chetan, for
Thank you.
showing all the recent advances and the basic training which is available at the Help Me See. For the residents sitting here, this simulator is already in here too, in the SSTC area. If you get time, then must visit there.
It is available in the SSC. We are lucky, all the PGs, they can go and learn there. They have not to pay anything for that. They can go and study there.
Yes.
So we have Dr. Satanshu Mathur, who is now perhaps the main force behind this meeting as its organizing secretary. He is a very prolific surgeon and a very, very enthusiastic person in all organizations, AIOS, the Uttarakhand Society, ISMS, So, Satanshu sir, if you could tell us more.
I thought I will not have to speak, but one speaker is missing, so I have to come to speak because still we have time. So, this is a video-based session because this is not the technique for the persons who are starting the SICS surgery. If you have mastered the SICS surgery, on to the video. If you have started so this is, once you have started the SICS surgery, mastered the surgery, then you go for this because this is the nuclear division, means you have to remove the nucleus from a small incision. So what is the steps in nucleus division? This is the nucleus management. So what are steps? First is dislocated nucleus out of the bag, then deliver nucleus into the antechamber, and then deliver nucleus out of the eye. So these are the basic steps in any nuclear delivery. So what are the techniques for dislocating nucleus out of the bag? This is hydrodissection technique or the dialer or hook technique. We have 2 dialers. Prerequisite for easy nuclear plus, adequate size axis, good hydrodissection, adequate size corneal scleral incision. Do not hesitate to make a big incision if the nucleus is hard. Surgical goal is protect the corneal epithelium and preserve the capsular bag. These are our aim of any surgery with phaco-SICS. This is the hydrodissection technique. We push copious amount of fluid on one side. In one single push of the fluid, nucleus comes out, and then we rotate it and then pull aside. This is dialer technique where 2 dialers are used. Rotate the nucleus, push on one side from dialer and take it out of the nucleus. So there are 2 techniques to bring the nucleus into the antechamber, where hydrosection technique for the soft cataract, and the hard cataract you use the dialer technique. This is a basic skull tunnel. The external incision, normally this is for the beginners. So minimum 6.5 you have used, 6 or 6.5. Then internal incision becomes 7.5. Once you have master surgery, now we are doing from 4 millimeter. One of Dr. Sao is doing from 2 millimeter incision also. Many of us started doing 2 millimeter. First, starting surgeon should start from big incision, because big doctors, you have to become the big doctors, you have to make the big incision initially. So this is the once outside, 1.5 millimeter from away from the limbus, and 1.5 millimeter into the inside the limbus. And inside incision you have to make side pockets that make the incision 7.5. So you have increase the intraocular pressure inside the eye. The nucleus comes out. Once you engage in the wound area, pass over the posterior lip of the wound, like a fish mouth is opens and nucleus comes out. So this is the basic principle. They open a closed chamber surgery. When we lift the upper lip, we close the groove. When press over the lower lip, we divide the groove. Now I come to the point that once you master the SICS surgery, you have to make now the incision smaller. So you have to fracture the nucleus. It can be intertunnel fracture, it can be fracture in the anterior chamber. So there are different techniques. You can try every technique. Whatever you like, you can do it. Because we have tried everything, now we have come to the this is the best for us. Intertunnel fracture. Increase the, this is the nuclear chamber, vectis. Incision is small, so when it comes in the wound area, it divides it two. This is the irrigative vectis. Take it out. It divides itself in the wound area because it is small. We again go inside and we take it out. So we have once incision is small, so itself nuclear divide at the wound area. It does not cause endothelial damage because we are at the tunnel level. So once you have come to the intertunnel level, it will automatically divide two parts because there is no space to come the nucleus as such. When the second part is remaining there, you inject the fluid, inject the viscoelastic and take it out the second part. This is the fish hook case. Fish hook is simple 26 gauge needle. We bend it like this, and once we go inside, because size of the incision is small, so it will automatically divide the wound area. We go inside, hold it, take it out, and you see we are taking out in toto. This was bigger incision. Now in the fracture technique with the same fish hook, we have kept the incision small, so it will divide automatically in the two parts. You see, this has divided automatically into two parts. One part has come out, one inside. So initially we have to try always with the big incision, and then we have to try them with a small incision. Now again injective fluid, viscoelastic, and the nucleus is beginning in the center, and second part will be moved by in second attempt. So in first case we have taken out in toto, and here we are taking out two pieces. So every technique we can divide the nucleus two parts. This is fish hook made by 26 gauge needle. This is sandwich case. In first case we take it out as in toto. The whole one vectis go behind, and the second dialer goes in front of the nucleus. Hold it and take it out. It's a very good technique for the hard cataract. We are taking out in toto. Means incision was is big. Now you want to break the nucleus. So make the incision small. Again the same thing. One instrument goes behind and one instrument over the nucleus. This is simple as depositor. Nucleus is divided in two parts. You can see one part is still remaining inside the eye. Okay. So now you inject the viscoelastic, again go inside and take out the second part. So in every technique you can divide the nucleus, you can came out in toto. This is viscoaspiration technique. Just inject the viscoelastic behind the nucleus, press over the posterior lip of the wound, nucleus will come out automatically. Because nothing is going, instrument is going inside. This is a very safe technique because your instrument is not going inside. You can take it out easily. This is removal of the nucleus in toto. Then viscoaspiration, when we want to remove the nucleus, in divide in two parts. This is cannula takore, you see. What we are showing, we are same thing we are doing. This is a special instrument. We go just behind the nucleus with this is 20 gauge cannula. Just press and nucleus comes out. Viscoaspiration. We can name it anything. This is the hardest nucleus, we can take it out. We are just taking this cannula, I want to show this special cannula. So that goes inside and just that the viscoelastic comes out. This is blow menthol technique where we have to induce a infusion calorie at the 6 o'clock and then nucleus comes out automatically because there is increased pressure inside the eye. So there are different techniques to remove the nucleus outside the eye. We have shown almost every technique that is available in the world for nucleus removal, and then you can see what technique is good for you. Then manual fracture. We can divide the nucleus manually also inside the eye. This is the second instrument. First instrument go now. We have divided the nucleus in two parts by the dialer only. Then this is a snare that was used, I am not using nowadays. We can use this snare, you cut the nucleus in two parts and then you can take out the one part one by one. So there are many techniques to divide the nucleus intertunnel and the inside the eye. This is snare technique. This is snare that is available in the market, and then you can divide the nucleus in two parts or three parts, whatever you want. That Ramesh Shah is very, and you can see the incision is 4 millimeter. In all the cases, incision is almost 4 millimeter. So there are different techniques to use in the SICS. You can use whatever you like. Once you master the surgery by 6 millimeter, then you come to the 4 millimeter, then you come to 2 millimeter. So we have many options in SICS, not so many options in FICO. So one of request to all of the younger generation also, beyond this ophthalmology, you should become the member of FBS. FBS is Family Benefit Scheme. Especially for the younger generation, you have to pay very less to secure your family. Don't think that your life is, pray for your long life, but you not secured. So you should not think that we are going to live many more years. You should join the Family Benefit Scheme, very good scheme. There is a stall near the SSCC area. Go and know the benefits for the younger generation to become the members. Thank you.
Thank you, sir. And we have still about 2-3 minutes, so we can take an odd question in case there is one. Okay, thank you.
We take a photograph and close the session. All the speakers.